It's a real life.
Okay.
Will you start, sir? We are live.
Yeah.
You'll start, sir?
Yeah. Let's start.
Yes, sir.
PowerPoint is not coming. PowerPoint is not coming.
Sir, whenever you tell, I'll change the slide, sir.
No, that PowerPoint I'm not able to see.
Acha.
Yeah, now it is coming. Yeah, now it is coming.
Right.
Welcome, welcome to all dear students with good evening, and me and there is a Dr. Rajesh sir, who is a medicine faculty. I am Dr. Devesh, who is a pathology faculty, and we have decided that we are going to conduct medicine and pathology integrated course for the students on the YouTube channel, so that we can have more clinical correlation with the pathology. And in that scenario, we have decided this month with cardiology integrated series, and you can see on your screen the dates are visible here. On every Monday night 8 p.m. we are going to integrate some beautiful cases. Like you can see now, we are going to discuss about rheumatic heart disease, then we are going to discuss about myocardial infarction, then next week we will be having cardiomyopathy, and next to next that we are going to discuss about infective endocarditis. So stay tuned with us. We are going to discuss, and definitely it is going to benefit you. Share the link with your friends so that they can join us. And welcome again to the Unacademy platform. Please, Rajesh sir, you also comment something about this.
Right. So, like, because our pattern of exam is going from NEET PG or the NEET to next. So, keeping that particular motive to help the students, we are coming up with this integrated series wherein we are integrating the pathology with the general medicine. Majority of the topics of your general medicine, they are completely in correlation with your pathology. So that is the reason why every Monday we have come up with the integration of the medicine topics with the pathology topics. So today we are starting with the rheumatic heart disease. In this particular rheumatic heart disease, this will be the overview of our presentation. That includes etiopathogenesis, diagnostic criteria we will be discussing, and in the diagnostic criteria, we have a modified Jones criteria, which I'll be discussing, clinical manifestations, and finally, we will conclude this particular session with the treatment. So first now, Devesh sir will talk about the etiopathogenesis.
So, dear students, as we all know that this rheumatic heart disease is a kind of autoimmune disorder, as you can see on your screen. It's an autoimmune disorder. Why it is an autoimmune disorder? And remember, I'm going to discuss about that thing, why it is an autoimmune disorder and who is causing. You can see this is by group A beta hemolytic streptococcal infection, right? In clinical part, sir will be discussing which age group is commonly affected. Usually it is the pediatric age group. But when this group A beta hemolytic streptococcal infection comes, right? So remember, it is secondary to the pharyngitis only. That is one important thing we have to understand. It is not secondary to skin infection. It is only to the pharyngitis. So that is the important thing we have to understand. Beta hemolytic streptococcal infection, pharyngitis will lead to the rheumatic heart disease, not the skin infection. That is the question in PGIN already exam. So next slide, I will be telling you about the why it is called as autoimmune disorder. Next slide, sir.
Right. So before going into the next thing, I just wanted to mention one point here. As sir have mentioned very clearly that it is secondary to pharyngeal infection of the streptococcus, the individual will develop the rheumatic heart disease. But one difference what you have to remember is you take post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, it is secondary to your pharyngeal infection and as well as the skin infection. So that is a very important difference what you need to keep in mind. Over to you, sir.
So it's a very correct point sir has told. When you have to understand, because this organism is for glomerulo PSGN also, glomerulonephritis also, and rheumatic heart disease also. But rheumatic heart disease is secondary to the pharyngitis only, and PSGN is secondary to both skin and pharyngitis, right? So as I was telling you, this is an autoimmune disorder, and this mechanism of autoimmunity is called as molecular mimicry or cross reactivity, right? So what is the meaning of molecular mimicry or cross reactivity? You can see here in this image, if you look at this image, right, you can see there is a streptococcal antigen, there is a cardiac antigen, and because of these antigens, if you look at the molecular structure, a streptococcal antigen molecule is similar to the cardiac antigen, right? That is why the antibody which is formed is getting confused, and now it is going to damage streptococcal antigen also and cardiac antigen also, right? Streptococcal antigen, no problem to our human body, but when they are going to damage our own cardiac tissue, that will be the autoimmunity, right? So now you can see that these are antibodies are now autoantibodies causing damage to our cardiac tissue, and that will lead to the rheumatic heart disease, right? So that is the basic mechanism. Now you can see that because of the similarity between the molecular structure, antibodies are damaging both of the structure. That is why it is called as cross reactivity. Very important MCQ which examiner will be asking. What is the mechanism of infection induced autoimmune disorder? Remember, it is not only for the RHD, for all kind of, remember, for all kind of things you have to remember, it is an autoantibody response. It is an autoantibody response where molecules are mimicking and cross reactivity is there between the antigens, and antibody will be damaging both. So in the next slide, you can see when this patient is coming with a rheumatic heart disease, and suppose we are seeing the specimen or after the autopsy, what will be the characteristic gross finding? You can see in this left side, you can see there is a so many small beaded yellow color granules are present over the line of closure of the walls. So these are like a verrucae. We can describe them as a verrucae or beaded vegetations, right? So these are verrucae or beaded vegetations which are present on, you can see they are present over the surface of line of closure of the walls, right? So that is why we describe these are verrucae vegetations which is present on the line of vegetation, line of the closure of the wall. And what are these vegetations made up of? See, because of the inflammation, these are consisting of the fibrin, right? So they are fibrinous vegetation. Remember that vegetations which you are seeing here is the fibrinous vegetation. In the gross examination also, you can see the red arrows are pointing toward the line of closure of the wall, and you can see so many yellowish brown deposits are there. These are all examples of the fibrinous vegetations which are seen in rheumatic heart disease. And if you look at another picture in the next slide, you can observe that how this fibrinous pericarditis, when this fibrin is getting deposited over the pericardium, and that is leading to the fibrinous pericarditis, right? So now you can see in both the diagrams, right, you can see the blue mark you are watching here, these are all fibrin over the pericardium. And the second heart specimen, it's a little older one, and there also there is a fibrin. This is the older one, that is why reddishness is less. And in both cases, if you look at them, and you compare with the third diagram which I am showing you here. There is a bread and butter is over there. So this fibrin deposition is giving appearance like a bread butter pericarditis, right? So this rheumatic heart disease, gross examination, you can see vegetations along the line of closure of the valves and bread and butter type of the pericarditis. And all these are, see, vegetation was also fibrin, and this is also fibrinous deposit on the wall, right? So when you see the microscopy in the next slide, when I'm going to show you this microscopic examination, next slide, if you look at this one, right, in the next slide, what I'm showing you here, next slide, sir. Next slide, sir. So in this slide, you can see I am showing you myocardium. There is a myocardium here. You can see in this arrow, this is the myocardium, and this area is the Ashkoff-Jand cell. Remember, it is also called as Ashkoff bodies or Ashkoff-Jand cell. Remember, I have written very boldly in the above column, Ashkoff bodies or Ashkoff-Jand cells are the diagnostic. Remember, these are the diagnostic of the rheumatic heart disease, not the Anaisco cells. Here I have written Anaisco cells. Remember, Anaisco cells will be, why they are called as Anaisco cells, you can see in this picture. There is a caterpillar-like nuclear chromatin, right? That caterpillar-like nuclear chromatin is the reason for Anaisco cells, and they are normally present in normal myocardium. So they are not diagnostic, right? So normal features are never diagnostic, and moreover, Anaisco cells are the part of Ashkoff-Jand cell. So please back up. So if you are coming back to the slide, I just, you see what I have written here in this slide, right? These are the Ashkoff-Jand cell, right? What is Ashkoff-Jand cell made up of? You can see the marking number one. Number one, you can see there is a myocardium, which is swollen myocardium, right? As I have shown you in that picture also, there is a swollen myocardium. Second, you can see there are two inflammation. You are seeing inflammatory cells. One is the lymphocytes and another one is the plasma cell. So lymphoplasmacytic infiltrate is there, right? And you can observe the third one is the histiocyte. Histiocytes, see, there are so many histiocytes, but some of the histiocytes are larger. Some of the histiocytes are larger and they are having caterpillar-like nuclear chromatin. These histiocytes, remember, these larger histiocytes with caterpillar-like nuclear chromatin, they are called as Anaisco cells, right? So now you can see that entire structure is this 1, 2, 3, 4. All these four things together are known as Ashkoff-Jand cell. So that entire four things I have clubbed here, they are diagnostic of the Ashkoff-Jand cell, right? Not the Anaisco cells, right? So that is the that clarity should be in mind when you are going for exam. This question had come 2 or 3 times consecutively in NEET PG exam in 2016, 17, and 18, right? So always remember, Ashkoff-Jand cell is diagnostic, not the Anaisco cell, right? So next slide, again I show you this microscopy. Now you can see in this microscopy, you can see these are the eosinophilic collagenous fiber. These are the eosinophilic collagenous fiber. These are the myocardium, right? And here you can notice there are so many cells which are the lymphocytes and plasma cells. Some of the cells are large, and I have shown you in this another picture where I am showing you Anaisco cells and marked this. And I have just took this cartoon picture of the caterpillar so that we can understand the nuclear chromatin is like a caterpillar. That is why it is called as a caterpillar cell also, right? In the next slide, if you see what you are observing in the next picture, this is the chronic rheumatic heart disease. What happens in rheumatic heart disease, as sir will be discussing more about detail about the valve involvement, that valvular involvement is quite common in rheumatic heart disease, and mitral valve is the most commonly affected valve, right? So what is happening here? Mitral valve is affected, and because of the chronicity, how you say the chronic inflammation, you remember chronic inflammation when you find fibrosis, right? When you find fibrosis, so you can see here there is a fibrosis. If you look at the blue mark which I had made here, right, these are looking like a fish mouth appearance or buttonhole deformity. So this fish mouth or buttonhole deformity is because of the fibrosis and calcification. This was the NEET question recently asked, right? Why there is a fish mouth or buttonhole deformity in chronic rheumatic heart disease? So it is because of the fibrosis and calcification, right? So this will be seen in chronic rheumatic heart disease, right? So always remember, chronic rheumatic heart disease, mitral valve is getting stenosed. There is a narrowing, that is the mitral valve stenosis. So chronic rheumatic heart disease, this is number one important finding which you will see on the gross examination, right? On gross examination, you are seeing fish mouth or buttonhole deformity because of the fibrosis and calcification. In next slide, I will show you another important, interesting point, and that is you can see this is the this is seen most commonly in chronic rheumatic heart disease, but it begins in the acute rheumatic heart disease. In acute rheumatic heart disease, there is a mitral regurgitation because of the backflow. Because of the backflow, the left atrium posterior wall is continuously eroded by the backflow. Because of that erosion, subendocardium is exposed, and on this subendocardium, there is a collection of the Ashkoff bodies, right? So Ashkoff bodies are coming, they are getting collected over the subendocardial area, and this is called as McCallum plaque. So you can see the blue color I had marked here and looking little pale. So that is called McCallum plaque, right? You can see that is the McCallum plaque. And what is McCallum plaque? It is subendothelial collection of the Ashkoff bodies, right? Subendothelial collection of the Ashkoff bodies. McCallum plaques are commonly seen in which area? Left atrium, posterior wall. Where you will see them most commonly, answer should be chronic rheumatic heart disease, right? So these are the important points about the gross finding, right? So now you can see chronic rheumatic heart disease, two important things you have to understand: buttonhole deformity, and the second thing is the McCallum plaque, right? So these are the important overview which I wanted to summarize here, that rheumatic heart disease is an autoimmune disorder because of the streptococcal infection of pharyngitis only, and mechanism is molecular mimicry, and due to cross reactivity, antibody is getting confused, they are damaging our own cardiac tissue, patient will develop rheumatic heart disease. And we have seen important kind of presentation in this. When you are seeing on gross examination, there is a fibrinous pericarditis or bread butter pericarditis. Microscopy is showing diagnostic Ashkoff bodies, and chronic rheumatic heart disease, we have seen McCallum plaque and buttonhole deformity or fish mouth appearance because of the fibrosis and calcification. So these are the important points about the pathology. Now Rajesh sir will be coming and he will be discussing about the clinical aspect of rheumatic heart disease.
Thank you very much, sir, for giving a great insight of pathology of the rheumatic heart disease. So now let me start the medicine discussion by giving you an insight about the criteria. See, the name of the criteria for the rheumatic heart disease or the rheumatic fever is the Jones criteria. Now, whatever I am showing you is the one of the old criteria, now in which you have the major criteria and as well as minor criteria. And if you take major criteria, there are totally 5 major criteria. Then how to remember these 5 major criteria? You can remember the mnemonic Jones. J stands for joint involvement, and let me tell you, the most common clinical manifestation in rheumatic fever is joint involvement. O stands for, O looks like your heart, which is nothing but your myocarditis. N stands for nodules, that is subcutaneous nodules. E stands for the erythema marginatum, and S stands for Sydenham's chorea. Now let me tell you a few points on the major criteria. Most common manifestation is your polyarthritis, migratory polyarthritis. Second most common manifestation is your cardiac involvement, right? According to the recent criteria, it is your pancarditis, that is endocarditis will be there, myocarditis will be there, and pericarditis also will be there. Next, the third important question is, which is the late manifestation? The late manifestation is Sydenham's chorea. So these three are your important multiple choice questions. Then coming to your minor criteria, like minor criteria, there are totally 7 minor criteria. Then how to remember? I'll give you a mnemonic for that also. The mnemonic is cave Paul. Let me tell you, your rheumatic fever is an inflammatory disorder. So your markers of inflammation, that CRP will be raised and ESR also will be raised. And A stands for arthralgia. Now very important point is, in major criteria, you will have arthritis. That means all the signs of inflammation will be there. Rubor, calor, tumor, and as well as pain. Whereas arthralgia, you will have only pain, not other signs of inflammation will not be there. And F stands for low grade fever will be there, elevated ESR, prolonged PR interval, Now, why do you have that prolonged PR interval? That vegetations will go and get deposited within the internodal fibers. So when vegetations goes and get deposited in the internodal fibers, the time required for the impulse to move from SA node to AV node will be prolonged, and thereby there will be prolonged PR interval. And A stands for anamnesis of rheumatism. What does that mean? That is past history of rheumatic fever. L stands for leukocytosis because it's an inflammatory disorder. So that is your major and minor criteria according to your Jones. Now, if you take the diagnostic criteria, what is required for diagnosis? All these manifestations are not required. Two major criteria, if they are there, okay, we can diagnose rheumatic fever. Or one major plus two minor are there, we can diagnose rheumatic fever. See, this was what the criteria for Jones from long back. Now we have revised Jones criteria, which is released in the year of 2015. Now, according to this revised Jones criteria, they have divided the population. How did they divide the population? They have categorized into low risk population and as well as high risk population. Now, first of all, you should understand what do you mean by the word low risk population. Low risk population means that particular population of child or school aged children, if the incidence of rheumatic fever is less than 2 per 1 lakh per year, or any age the incidence of rheumatic fever is less than or equal to 1 per 1000 population per year, this is what is considered as low risk population. So I'll repeat it again. School aged children less than 2 per 1 lakh per year. Any age less than or equal to 1 per 1000 per year, that is considered as low risk. Now, anything above this, more than 2 per 1 lakh school age, more than 1 per 1000 any age, that is considered as the high risk population, right? That is considered as high risk population. Now, according to your revised Jones criteria, we have the major criteria which is same. Carditis, it is same in low risk and high risk, and chorea, it is there in both low risk and as well as high risk, same. Erythema marginatum, that is also same in low risk and as well as high risk. Subcutaneous nodules, that is also same for low risk and as well as high risk. But what is the difference then? According to the revised Jones criteria, what is the difference? The entire difference is in your arthritis. In low risk population, there should be migratory polyarthritis. That word is very, very important. Whereas you take in high risk population, even if there is monoarthritis, that is fine. We can take it as a major criteria for high risk population, or it can be even polyarthritis as well. Not only monoarthritis or polyarthritis, let me tell you, even if there is polyarthralgia, that is also enough for considering it as a major criteria for both moderate and as well as high risk. So the entire difference in your 2015 revised Jones criteria is for this particular most common manifestation, that is arthritis. Now, let me discuss the minor criteria. Minor criteria also, it is slightly different for low risk population and as well as the high risk population. Now, you take low risk population. What all should be there? Polyarthralgia should be there. Low grade fever, temperature more than 38.5 degrees centigrade. ESR more than 60 in first hour. CRP should be more than 3 milligrams. Now, what is the difference of this in the high risk? In the high risk, monoarthralgia is fine. Polyarthralgia is not required to consider it as a minor criteria. Low grade fever will be there. But you take the ESR story. ESR in case of low risk is more than 60. ESR in case of high risk is more than 30 mm per hour. That is the difference in your low risk and as well as high risk in the minor criteria. CRP will be raised in both of them. That is more than 3 milligrams per deciliter. And PR interval also will be prolonged. So, to summarize the differences, in the major criteria, the joint involvement. In the minor criteria, joint involvement and as well as ESR. These are the three differences from your old Jones criteria to that of the new modified criteria. Now, You take the recent rheumatic update. What has been given in the recent rheumatic update is, okay, previously what they were telling, if two major criteria are there, diagnose it as rheumatic fever, or one major criteria plus two minor criteria are there, diagnose it as rheumatic fever. But what is given in the recent update? The recent update, what has been given is, if there is recurrence of rheumatic activity and if three minor criteria are there and there are no major criteria, even then you can consider it as rheumatic fever. Right? Even then you can consider it as rheumatic fever. And not only that, in the recent update, they also have taken the echocardiography for the diagnosis of the subclinical carditis. Right? Echocardiography also they have taken. So this is your criteria part. That is your Jones criteria and modified Jones criteria. Then coming to your valvular involvement. Let me tell you, these 3 points are very important multiple choice questions. What is the most common valve involvement? Mitral valve. Whereas in acute rheumatic fever, the most common valvular pathology is mitral regurgitation. In chronic rheumatic heart disease, the most common valvular heart disease is mitral stenosis. But if the question is asked, overall, what is the most common valvular pathology? Then the answer should be the mitral stenosis. Right? Answer should be mitral stenosis. Okay? Then, so this is about your valve involvement. Which is the most common affected valve? That is your mitral valve. Then, followed by that, what are the other valves which are involved? The other valves which are involved is, aortic valve is the second most common valve involved. Tricuspid valve is involved. Least commonly affected valve is your pulmonary valve. Right? Least commonly affected valve is your pulmonary valve. Right? Next. Now, the other important point is, just one second. Yes. Now coming to the treatment. What is the treatment for this particular rheumatic fever? Let me tell you, what is the most common involvement? Most common clinical manifestation? That is arthritis. So for arthritis, you need to give high dose salicylates. And how much of the salicylates you will give? You need to give 75 to 100 milligrams per kg of salicylates should be given in 4 to 5 divided doses. That is the dose of your salicylates. The other alternative agent is the steroids can be given in order to reduce the inflammation. Now the question is, for how many days you need to give these salicylates and steroids? These salicylates or steroids you have to give until the ESR becomes normal. Right? Until the ESR becomes normal, you need to give the salicylates and as well as steroids. Now, you take the salicylates. What is the very important adverse effects of your salicylates in children? What is the important adverse effect of salicylates in the children? Yes, anyone? Right. So the most important adverse effects of salicylates in children, very good Simran Gupta. So that is your Ray's syndrome. Now, first suppose if the individual has developed Ray's syndrome, then what is the alternative drug? The alternative drug what you can give is naproxen. Right? The alternative drug what you can give is naproxen. Naproxen can be given if the individual develops the Ray's syndrome. Now, because of myocarditis, the individual also develops heart failure. And if the individual develops heart failure, what is the treatment? Fluid restriction, diuretics, oxygen, and as well as the digitalis or digoxin should be given. That is when if the individual has developed the heart failure. Right? Next. Now, the other important manifestation is your chorea. Right? I said you about the chorea. What did I tell you? Chorea is the last manifestation in the major criteria of your rheumatic fever. By the time chorea develops, other manifestations they disappear. And for mild cases of chorea, you need not give any drugs. Just provide the calm environment, that will be enough. And in moderate cases, you need to give carbamazepine or valproate, that is preferred over haloperidol. Both of them are your anti-epileptic drugs. Carbamazepine, it is a drug of choice in case of your focal epilepsy. Valproate, it is a drug of choice in case of your GTCS, generalized tonic-clonic seizures. Whereas in severe or refractory cases, you need to give steroids. Right? In severe or refractory cases, you need to give steroids. So this is the management of chorea in patients with the rheumatic fever. Right? Now, okay, see, your rheumatic fever is a recurrent disorder. Right? The individual can get affected by your group A beta hemolytic streptococcus recurrently. So for them, the American Heart Association has given a guidelines. You have to give this particular benzathine penicillin. Right? What is the antibiotic you will be giving for your group A beta hemolytic streptococci? That is benzathine penicillin. How frequently you have to give? You have to give this benzathine penicillin every 21 days you have to give. Okay, fine, I'll give every 21 days. How many days I have to give? Now you need to know this table, very, very important. If there is no carditis, only rheumatic fever is there, give that particular benzathine penicillin every 21 days for 5 years after last attack, or up to 21 years of age, whichever is longer. For suppose, if the individual is having carditis, rheumatic fever, carditis, but no residual valvular damage, in such case, you need to give benzathine penicillin 1.2 million units for every 21 days up to 10 years after the last attack, or 21 years of the age, whichever is longer. For suppose if the individual is having a valvular damage, then you need to give this for 10 years after the last attack or up to 40 years of age, whichever is longer. So that is about your duration of your prophylaxis. And what is that antibiotic you need to give? Benzathine penicillin is what you need to give. And what is the dosage of your benzathine penicillin? 1.2 million units. And the route of administration is you need to give deep intramuscular. If you give intravenously, let me tell you, the individual will have anaphylactic shock and he will collapse. Right? You should never give IV. You should give deep IM. And this is like when the weight of the individual is more than 27 kg. For suppose, if the weight of the individual is less than 27 kg, the benzathine penicillin what you should give is 6 lakh units you need to give. 1.2 million units more than 27 kg, 6 lakh units less than 27 kg. Now, for suppose, doctor, I am very much allergic to penicillin. Then we have alternative drugs also. The alternative drugs are erythromycin can be given, sulfadiazine can be given, right? Erythromycin and sulfadiazine. These are the alternative drugs what you need to give for the prophylaxis if the individual is allergic to your benzathine penicillin. Now, as we have integrated the pathology and as well as medicine, now let me show you some of the multiple choice questions and let me see who will answer this question first. A girl present with Sydenham's chorea, which is the best test to prove recent infection? ASO titer, brain biopsy, anti-hyaluronidase, throat swab. Yes. Very good, Yashram. So the answer is the ASO titer. So ASO titer is the best to prove the recent infection, right? Next, very good. Now you take the next question. Which of the following drugs is recommended for refractory Sydenham's chorea? Steroids, haloperidol, carbamazepine, valproate. Right. So I can see, yes, Rajkumar and Priyank Trivedi, Simran Gupta, everyone is answering. Very good, excellent. So the answer is the steroids. So steroids are the one which has to be given for refractory Sydenham's chorea. And the last question. What is the true statement about the erythema marginatum in acute rheumatic fever? Pruritic, commonly involves the face, common manifestation of acute rheumatic fever, usually associated with carditis. Right. So the answer here is very good. Ravi has answered this question. Very good, Ravi and Danish. The answer is it is usually associated with carditis. Let me tell you, erythema marginatum, it is a non-pruritic rash. and it commonly involves the trunk. It does not involve the face, it commonly involves the trunk. And it is not the common manifestation in acute rheumatic fever. What did I tell you? The common manifestation in acute rheumatic fever is your polyarthritis. It is not your erythema marginatum, right? So, and this is the manifestation which is usually associated with the carditis. So these are some of the questions related to your acute rheumatic fever. So this is how we can integrate the pathology and as well as medicine related to this particular topic of rheumatic heart disease, right? So over to you, sir.
Yeah, so that was a very fine interaction and fine explanation by Rajesh sir. And this is going to happen every week. So next week we are coming up with the next topic. So I request all of you students to share this and share with your friends so that maximum student can have benefit from here. And we will incorporate more interesting cases in future also for the discussion, right? So these are the important things you have to understand how to correlate the pathology with the medicine. So now you can see both things are there and you can correlate these things together and you can expect some question in your exam, because as sir has said, next exam you are going to have this kind of fine clinical questions. Even not next, even in the coming aims exam you will be getting some question from this discussion, right? Yes sir,
So thank
over
you
to you
very
sir.
much, guys. We will see you on next Monday with the topic of myocardial infarction.
Thank you
Thank you,
so much to all
sir.
of. Thank you.